So this is a case of ASD device closure in a 38-year-old female presented to me in OPD with the complaints of dyspnea on exertion and palpitations. So to do any ASD, I would like to start with checking PA pressures, because these patients, long-standing ASD, they will have at least mild to moderate pH, and some cases of ASD they will have since birth moderate to severe pH. So before device closure, you have to cross check the PA pressure twice. In this case, PA mean was just 15. So this is my catheter, multi-purpose catheter from IVC, RA, RV across the RVOT into LPA. So now I have finished that PA portion. So this is my catheter from IVC, RA across ASD into LA into left upper pulmonary vein. Now I'll park a stiff wire across this ASD, and this lady was having fenestrated ASD, so my plan was to balloon size the ASD and then take a effective proper size of device. So this is 34 mm sizing balloon I have sized. You see the measure waist, it was coming 19 into 23 in orthogonal views. So this was coming 23, in AP it was coming 19. So I have taken 24 mm septal occluder. So deployment wise, so first I'll put the sheath across ASD into LA. I'll load my device. You have to be cautious that there should not be any air inside the system, because if air goes, it will go to LA, LV, aorta and into the right cusp, because that is anterior. So patient will have ST changes in lead 2, 3, AVF. So this is my deployment. So first I have released LA disc. I have pulled the whole assembly till I got resistance, and then I have peeled the sheet to release RA disc. So I am cross checking in LAO view. This is Minnesota. I am wiggling to see whether device is holding properly or no. So I rechecked it in echo. It was sitting properly, holding all the margins. Then the device was getting released. Device release, it is sitting properly.
What can be the complications for this ASD device closure?
So as I have explained before, the most common and most dreaded complication is air embolism. I have seen patient going on ECMO because of RC embolism leading to ventricular dysfunction, but they recover quite well. Second thing is, you can, while trying to go into pulmonary vein, you can
there be that much amount of air also which may lead to systemic air embolism?
One bubble of air at correct position is more than enough.
No, for systemic air embolism.
Systemic air embolism means aorta.
Like, yeah, going to the brain.
It can go. It can go if you are not cautious.
So what precautions one should take?
Air-free system. Most of the things you should do underwater for ASD. So while trying to cross the ASD at the first go, you might damage the LA appendage here, or while trying to go to SVC, you might damage the RA appendage here. So you have to be cautious, and while pushing the sheath, again you can damage the appendage here or the roof of LA, and then air embolism, as I have told you before. After that, post device, you can have blockage of, patient can have block because the device might be impinging near AV node, or the device can embolize. So these are the most common.
Normally it embolizes where?
Generally it embolizes to RV.
And then can it be removed?
Yeah, if it is a smaller device, it can very well be snared, but difficult to snare the bigger ones.